We're going to give it a minute or two for other folks to join, and then we'll get started. And Laura Dagley will be our moderator. Thank you.
And I just want to note, if you have any questions during the webinar, to make sure to put that in the chat, and we'll get to those questions at the end. We will go ahead and get started. So thank you for joining us today for our webinar, Drivers and Outcomes of Pollution Disparities in Louisiana's Cancer Alley. My name is Laura Dagley. I am a nurse and the medical and environmental health writer for Physicians for Social Responsibility in Pennsylvania. I'm based in Pittsburgh. And today we have with us Dr. Kimberly Terrell, who is a research scientist and the Director of Community Engagement at the Tulane Environmental Law Clinic in New Orleans, Louisiana. And she is going to be presenting some of her research alongside with Gianna St. Julian, who is the researcher and community engagement specialist at Tulane Environmental Law Clinic. And I will be sure to drop their extended bios in the comments because they're impressive and quite long. But they're going to be discussing some of their research around the communities impacted by industrial pollution in Louisiana. And we will be discussing afterwards about what they learned and how that's relevant for other communities facing similar issues. But first, we have Ursula Tenue, who is a member of the leadership team of the grassroots advocacy group Stop Sterigenics in Willowbrook, Illinois. And she's going to tell us some of her story about going up against a polluter and winning. So I'm going to pass it off to you.
Let me start a screen share so I can put a bunch of pretty pictures in front of you while I talk. Good afternoon, and thank you for including me in this conversation and for your interest in advocacy for a healthier environment. My name is Ursula Tanaway, and I'm a member of the leadership team of the 100% volunteer-run, grassroots, issue-based community group Stop Sterigenics. I'm a research microbiologist by training, but more recently I've gained much more experience in governance and advocacy through this process. I serve in my local political party and as an elected school board member for my elementary district, so I did a deep dive into this. Today, I'm hoping to give you some tools and tips that are broadly applicable to the environmental advocacy, so you can begin thinking about how to apply the information Dr. Terrell and Ms. St. Julian will cover in the next segment. I'll start with some very basic information about ethylene oxide and my community's journey, and then speak to the role that healthcare and public health professionals, nonprofits, and an issue-educated and empowered public have played so far in what's become for us a national advocacy movement concerning our air toxic. My community's environmental advocacy journey began in August of 2018. An updated cancer risk value had recently been finalized for ethylene oxide by the Integrated Risk Information System, or IRIS program at EPA. And the US EPA had used that new risk value together with self-reported emissions data and calculations from permitted polluters in their screening tool for cancer risk, the National Air Toxics Assessment Tool, or NATA. Ooh, that went fast. Before the updated NATA was publicly released, EPA employees at a warehouse in a light industrial area of Willowbrook, Illinois, right outside Chicago, had noticed a large risk spot centered on their place of work. And EPA Region 5 had arranged for some preliminary ambient air testing and a consultation from the Agency for Toxic Substances and Disease Registry, ATSDR, which is housed under HHS and CDC. The hotspot was centered in an office park zoned for light industrial at a business called Sterigenics, where those red marks are. The Willowbrook Town Hall and police station are across the street. Athletic spaces for swimming and soccer and general training are all up and down that north-south street. A Target store is right next to building 2. Sterigenics looked like a storage warehouse with a little office out front. There were no large storage tanks or smokestacks. There wasn't a chain link fence or security entry onto campus. It was hiding in plain sight just a block from the start of residential neighborhoods with schools and parks. Sterigenics put in their buildings in 1984 and 99. The residential areas around it were built in the 60s. Schools were put in 65, 67, 81. Those big red lines are 1 mile to give you a sense of scale and distance. Sterigenics chose a warehouse in the small light industrial park bordered by retail shopping strips and nestled in a primarily residential area. Despite explicit concerns in writing about their expected emissions from our state environmental agency, they chose the site for their own reasons without consideration of the health and safety of their commercial, governmental, or residential neighbors. Ethylene oxide is a potent mutagen that's been known to be a carcinogen for decades. It's mostly used in manufacturing as a building block for more complex chemistry. It's also one of the toxics emitted by the overall fossil fuel industry. A small percentage of ETO use by volume is in the sterilization of medical devices and the fumigation of foods and spices, like nuts, cosmetics, some other sundry commercial products, but this use, sterilization and fumigation, is responsible for the vast majority of community exposure to ETO. And unlike irradiation, there's no uniform labeling requirement for products treated with ETO, but there are some ISO standards for residuals in the process. International bodies, including IARC, had indicated that ETO was a probable human carcinogen for a long time. In 2016, the EPA's IRIS system finalized its updated report for ETO. They relied on decades of evidence and particularly on a large longitudinal study of the sterilization workers that used this chemical and were exposed to it in high amounts that was published in the early 2000s. And that provided solid evidence that ETO causes blood and breast cancers in humans. The inhalation risk value, inhalation unit risk value, indicates that lifetime exposures at the parts per trillion level increases cancer risk. Additionally, the estimates of the half-life of ETO in the air range from 70 to 150 days. By the time ETO that's emitted at a point source, like our local sterilizer, by the time it's broken down in the environment, and that 5 to 6 times the half-life time span where we consider the remaining amount to be reasonably small has passed, it's traveled across the globe many times, contributing to global baseline ETO levels. No wonder 1/3 to half of Americans will experience a cancer diagnosis sometime in their lives. In the healthcare space, you have a very intimate familiarity with the toll that illness and death take not only on the individual patient, but also on that person's entire support network. I was on an advocacy trip earlier this week where one of my coalition partners had flown to DC, leaving behind his girlfriend, whose aunt had just passed away from a cancer strongly associated with ETO exposure. She left behind a spouse and 2 young children. This colleague was also working with young partners in his organization, with multiple family members going through cancer treatments, battling the same pollutant-associated cancers. In my community, we talked with our neighbors and found cancers in every household, multiple cancers per household, multiple per individual, up and down the street from the polluter. As teenagers, we attended high school with a notably large number of teachers who had adopted children because they had fertility issues. As moms gathering for story time or in the park, none of us had to explain what a nebulizer was because we all had children with breathing issues. In some homes, the exposure was high enough to cause neurological symptoms, brain fog, frequent coughing fits. We know these ailments are common, but the scale was unbelievable. And the toll of human and community suffering dealing with the effects of pollution was immense. So when the village mayor, who was also going through health issues of his own, received these reports, the NADA and the ATSDR consultation, he put them on the village website and called his contacts in the state legislature for help. When Region 5 took down those reports from their website due to pressure from political appointees, and the village was asked to do the same, our mayor refused. Instead, within a week, he and our state representative and state senator gathered a panel of key people in a local banquet hall, including our congressmen, representatives from Region 5, ATSDR, a state regulatory agency, and the polluter. And on the community side, we helped advertise the public event to answer questions about the reports we'd just been given. I made flyers and handed them out in the school pickup line. We dropped them up and down our streets on doorways. We caught neighbors and told them to come. We used social media. We filled that banquet hall with residents looking for answers, and our congressman opened the meeting. The panel started explaining their reports and the air toxic screening tools and the collective emotions from all those years of pain and loss and human suffering over decades bubbled to the surface as we all connected the information we were given to our lived experiences. That's when the structured meeting broke down, with a sitting congressman being shouted down into silence. You see, we happen to be a highly educated community compared to the state average. Argonne National Labs is in our backyard, and we're a solidly middle-class bedroom community with a healthy mixture of hard work ethic and education. Our congressman is a physicist. Enough of us saw right through the platitudes and misdirection and industry propaganda. Enough of us were too angry and hurt to be polite. There was a line of community members wrapped around that room waiting to ask some questions, but mostly to share their experiences and frustrations, their anger and their grief. After that meeting, a protest was organized. And after that, a key group of individuals with different backgrounds and skills came together to talk about our goal of forcing the polluter to leave and a roadmap for how to get there. Our team included individuals skilled in sales, graphic arts, political organizing. We had health professionals, attorneys, and scientists. We pushed back on misleading or downright false industry narratives with truth and context. One outright lie and narrative that the ethylene oxide sterilizers trade groups tried to sell to our community and many others like ours is that there are countless sources of the pollutant in nature and in our daily activities. Things like rotting bananas and charcoal grills and diesel truck exhaust. They claimed that their contribution to ambient air levels of ETO was tiny compared to other sources. We suspected this wasn't true, and we were lucky enough to have the data to prove it. This graphic from an EPA presentation shows data from EPA's months-long ambient air measurements of ETO at various locations in the surrounding community, like the town hall, our schools, our parks, sports facilities. The x-axis shows time from mid-November 2018 to the end of March 2019. The y-axis shows concentrations of ETO in 24-hour ambient air samples analyzed by GCMS. The left side of that graph shows ETO levels while the facilities were operating under the best controlled conditions in their history. Additionally, the Village of Willowbrook contracted their own ambient air monitoring, both indoors and outdoors in a few locations. It was the combination of these indoor and outdoor measurements that prompted our state to take action on Valentine's Day in 2019, where that vertical blue bar bisects the graph into those two distinct areas. There was a seal order placed on the canisters of ETO at the facilities that completely shut down all sterilization operations. The measurements to the right of that graph show the contributions of the non-sterilizer sources of ETO in ambient air that industry was saying was contributing so much, like diesel trucks and rotting bananas and charcoal grills in Chicago in February. We love that one. I love the takeaway message this graph shows that puts industry's misleading claims into their proper context. We organized, provided information, and asked for help, and our community responded and participated. Protests, postcards, hearings, lawsuits, village council meetings, fire protection district meetings, county board meetings, state and national advocacy trips. Our community just came out in droves. We had some fun social media memes and postcards. Our kids participated. We had blow up balloons. We were fighting. We lost time with our families and skirted by as much as possible at work, letting career building take a back seat to the advocacy work that felt like a fight for our very survival. My children had attended more public governing body meetings by second grade and kindergarten respectively than most adults will attend in their lifetime. We passed 2 state laws, severely decreasing fugitive and stack emissions limits and increasing regulatory burdens and setbacks. The new sterilizer was named after Matt Haller in the picture in the corner. He was a young dad who was a professional ice skater. And he was the first community member who died of cancer after we found out we were being poisoned. And then suddenly, In September of 2019, we won. Our sterilizer of 34 years decided to shut down their Willowbrook facilities and not pursue a permit renewal under the new state laws and relentless public scrutiny. We all learned more about ETO and its regulation than we had ever cared to know, and we've seen a change in the overall narrative. There's recognition that the status quo cannot continue. There's still plenty of work to do, but now it's not just us in Willowbrook. We have partners across the US, in Texas, California, Maryland, Virginia, New York, Puerto Rico, Missouri, Colorado, and some invaluable nonprofit partners. We worked incredibly hard for our result, but we also got incredibly lucky with many situation-specific factors, and we don't forget that. I personally see it as my moral obligation to continue to volunteer my time in this advocacy and education, especially with environmental justice communities who by and large are less resourced and experience much greater burdens from all sides. We climbed a huge learning curve, and we can help give other communities a running start by sharing our knowledge and experiences. But the biggest factor keeping me and many others in Stop Stereogenics here in these conversations is that we know what it feels like to be in a community impacted by environmental pollution. Some more pictures. These were incredibly productive meetings and trips. So let's circle back to the roles we can all play in working together to create a better, safer, healthier world. As care providers, you're accustomed to hearing plenty of questions. Before you dismiss environmental health effects as simply individual patient cases, take the time to do some side reading and see what you can learn about the resources that the EPA, ATSDR, and your state health department have to offer. Our Department of Public Health had long known that our county had elevated breast cancer rates, but there was an assumption that the rate was due to high-income women who use dry cleaning services. Their assumptions were clearly wrong, and they recognized that in their report when they took a closer look around our facility. Dive into some primary literature to see what supports and does not support the claims being made. Consider reaching out to some resources that are available for quality information, like the PASHU network. Ours in Region 5, we're happy to answer questions for adults and provide continuing education credits for healthcare providers that focused on our pollutant of interest. Reach out to the Union of Concerned Scientists and Earth Justice. In a moment, you're going to hear more about environmental law clinics as well. If you don't get a helpful response from one resource, reach out to another. If you have the training and skills to read primary literature and larger compiled reports like the IRIS and IARC reports, and can help create like situational specific fact sheets, those can be very helpful and targeted to your audience. If like this was my role to do that, translating technical communication so it's relevant and understandable, and providing the relevant context, like explaining those graphs that EPA hides in its little PowerPoint presentations. Reach out to medical societies you or your institutions are already connected with. Expect some resistance, but be persistent. If you have or want to make connections with grassroots groups or create one like we did with a like-minded group of neighbors, do so. It takes a broad range of skills to run a movement like this. And with that, I will hand it off to Dr. Terrell and Ms. Gianna St. Julian, who will touch on some more of these themes, including the tyranny of the 0.05 in studies, and why we should consider risk the alarm bell before it becomes that 0.05 significance level that we experience with widespread harm.
Thanks so much, Ursula. I'm going to go ahead and share my screen, but my colleague Gianna is actually going to start the talk, and we are both from Tulane Environmental Law Clinic. Gianna, so I think you should be able to go ahead and get started.
Okay. Hi, everyone. My name is Gianna St. Julian, and I'm joined by my colleague, Dr. Kim Terrell. As she said, we're from Tulane Environmental Law Clinic, and we're going to be giving kind of a presentation based on some examples of data misuse, research gaps, and the burden of proof that's often placed on communities to show that there is an active problem going on as far as pollution exposure in a lot of communities. And then we're also going to dive into a study that Kim and I did involving a community or many communities in Louisiana. Yeah. So Tulane Environmental Law Clinic was established in 1989, and it engages in both education and legal advocacy, meaning we have a team of law students who work on many of the cases that the clinic takes on. The clinic also engages in public interest law, so the work is pro bono, meaning no cost to the communities that we help out. And the clinic is client-driven, along with the research that Kim and I do. So basically, the research that we do is based off of concerns that community members will bring to us and a lot of the issues that they're experiencing. So just as Ursula said, I do emphasize, the fact that research is very important, but it is the communities that truly make the work we do impactful. And so any community members that are here, I definitely encourage you to reach out to your local environmental law clinics, along with many of the other resources that Ursula listed in her presentation, as those are all very valuable resources when you're engaging in a lot of environmental justice battles. Okay, just as some background into the origins of the environmental justice movement in Louisiana, here are a few things that kind of sparked a new way of thinking in our state. So in 1978, a young truck driver was killed by inhaling toxic fumes at a Bayou Sorrel waste site in Iberville Parish in Louisiana. And this was an unregulated waste site. So no sign that this was a extremely harmful place of many chemicals being dumped here. Also from 1983 to 1988, the town pharmacist in St. Gabriel, Louisiana, which is a very tiny, heavily industrialized town with a population of about 4,000 people. The pharmacist, she noticed that there was an increase in miscarriage medication that she was prescribing to women in the town, over about 60 women. So she kind of started to take note on this informally, and eventually kind of brought that to light to the people living in this area. Also in 1987, the United Church of Christ released a study of toxic waste and race in the US, which found that industrial sites are disproportionately located in communities of color. So now, once again, these aren't, all of the historical EJ events that have taken place in Louisiana, but these are definitely some that sparked a new way of thinking about pollution exposure and regulating pollution in Louisiana. Now, it's important to note that all of the pollution data that we're going to be talking about in this presentation are ultimately based off of self-reported emissions from industry. And when it comes to air monitoring in Louisiana, the vast majority of the fence line communities don't have air monitors. And the few that do, the monitors only measure a handful of pollutants at most. And in this way, the burden of proof kind of always falls on the communities that are being affected. We often hear that there's no evidence of these cancer and emission burdens, but if there's no research, then there will be no evidence. So this is kind of the way that the data gap always seems to benefit the polluters, unfortunately. And the misuse of science against communities is another big thing that we experience in Louisiana. Like I said before, the lack of research kind of points to there is no evidence of a problem, but we know that that's not true. Just because there's no evidence doesn't mean that there isn't a real problem happening. Another way that misuse of science can be used against communities is a lot of the research we do have is kind of flawed in the study designs of reports and analyses that we have. Some ways that those designs are flawed is they have exposure misclassification, often failure to account for confounders and interactions such as poverty or race, and also they're statistically underpowered. So in Louisiana, a lot of the communities that we represent at the clinic are in rural areas. So these are small populations that we're talking about. And unfortunately, statistical power is basically the ability of an analysis to detect an effect if that effect exists. And when you're dealing with these small rural populations, you're going to need a bigger effect in order to rise to that threshold of statistical significance. So that's something you definitely have to account for when you're doing research in rural populations. Also, as far as Louisiana's previous research, there weren't many studies that were focused on pollution-related health outcomes in Louisiana or Cancer Alley specifically, which is an area in between Baton Rouge and New Orleans where there's a lot of heavy industrialization happening. And the ones that they did have as far as research, they didn't capture the full picture. For example, the studies shown here, which I'll go into more detail into momentarily, were published in 1982, 2004, and 2010, but they weren't robust enough to truly identify the problem, and much of the necessary data wasn't even available at this time. So some of the previous studies also didn't include pollution data. For example, the study shown here by Tsai et al., they looked at mortality rates and they actually lumped people into singular rates for their parish or county, but they didn't account for any variation in pollution exposure. Additionally, some other studies, they may have included some method of pollution exposure, but they didn't have a large enough sample size to actually detect the effect. For example, the study shown here by Simonson et al., they looked at about 450 lung cancer cases, but only about 22% of those cases were people who had ever actually lived within a 1 mile buffer of any active industrial site. So this makes the sample size much smaller, since many of those cases never actually experienced the exposure of concern here. And lastly, another study, or one shown here, didn't account for other factors that affect cancer incidence. So Gottlieb et al. Looked at mortality rates based on how closely people live to industry, but they didn't look at the influencing factors such as poverty or exposure rates, which overall contribute to Louisiana's data gap. So with respect to kind of the interpretation of cancer data, there are some important considerations that we need to keep in mind. So one is that the data presented in the Louisiana Tumor Registry annual reports, which the Louisiana Tumor Registry is Louisiana's state cancer registry. But they make these reports annually that make comparisons of an area called the Industrial Corridor or Cancer Alley, which is shown here in that orange area. And they compare this entire area to the rest of the state. And these comparisons have been used extensively in decision-making, so they do have real-world impacts. And when referencing this quote, which says industrial corridor rates for all cancers combined for white men, Black men, and Black women did not differ significantly from Louisiana rates. And what kind of jumps out to me first is that the Louisiana's statewide rate is not a gold standard. Louisiana actually has the second highest number of new cancer cases in the US. So if we're saying something is similar to the Louisiana average, that's not reassuring. And this gets at the point that these reports are actually pretty reliable and robust, but this is one of the comparisons that is super problematic and definitely contributes to the misuse and misinterpretation of data and reports in our state. So if we wanted to look at things kind of on a smaller parish level or census tract level, here we have a map of St. James Parish or county, which is an area in the industrial corridor or Cancer Alley where these questions and concerns about pollution and related health outcomes have received a lot of attention. And the data shown here is from the national percentiles of the 2017 Air Toxics Cancer Risk EJ Index. And this is a value that factors in pollution, race, and poverty. So previous approaches in research and decision-making would often group areas like this into one cancer incidence value. But in this figure, we can clearly see the variation in cancer risk from toxic air pollution that occurs when you're dealing with such demographically and industrially different census tracts within a singular parish. And it's important in research that we use and have a data set that more accurately reflects that local variation in neighborhoods in a parish and allows for a greater statistical power by having a larger sample size to use within those studies. So another point that's important to note is that we know that facilities that emit toxic air pollution exist in every region of our state. And in the map on the right, each square shown here is actually illustrating a facility that reports to the EPA's toxic release inventory. So we can see that, yes, there's definitely a high density of these facilities in that area known as Cancer Alley between Baton Rouge and New Orleans. But there's also many of these facilities in other parts of the state. And they have heavily industrialized, and they're always lumped in with those state averages and left out of the conversation since they're not in that industrial corridor. So for example, let's focus on that cluster in Southwest Louisiana. And if we zoom in This is actually what it looks like there. So this is a singular facility in Lake Charles, Louisiana called Sasso Chemicals. Now, hopefully this photo really puts into perspective not only the massive scale of these facilities and how the people facing the burden of pollution are right next door, but also that this is the type of industrialization that exists outside of the industrial corridor. You know, this is a common misconception that occurs throughout Louisiana, where you have these areas with heavy industrialization, some parts even more industrialized than the areas in the corridor, often being left out of the conversation. So in that previous example I showed with the Louisiana Tumor Registry reports compared, and when they're compared this area known as Cancer Alley to the entire state average, this means that the state average is the control group. But if places like this exist outside of Cancer Alley, then the control is also being exposed to pollution, which is extremely flawed or example of how this comparison is extremely flawed, and another prime example of data misuse. So now I'm going to pass it over to Kim to kind of expand on some examples of the way data can be used.
Thanks, Gianna. So in addition to the issue of flawed studies and lack of research, we also in Louisiana see decision makers taking legitimate data sets and legitimate studies, but misinterpreting and misconstruing that information. And this, I think, could potentially be very relevant to what you all in Pennsylvania are up against. So here's an example. This was from a recent state permitting decision where the state allowed a new petrochemical plant to be built. And in the decision, they looked at the local cancer rate in that community because many community members had made the argument that they were already overburdened by both cancer and pollution. So this graph illustrates that local cancer rate in orange, that's the orange bar, relative to the Louisiana average in light gray and the US average in dark gray. And so what you can see is that the number, the local cancer rate, numerically was higher than the state average and higher than the US average. But there's always uncertainty in your data, right? Any set of scientific data has uncertainty in it. And so in science, that's the point of statistics, is to decide, okay, yes, this is numerically higher, but is it statistically significant? So you see that black, what we call an error bar on top of the orange bar, that represents the range of uncertainty. So we think that the local cancer rate is just above 500 cases per 100,000 people, but that those error bars tell us that we're 95% sure that the actual value is somewhere between about 400 and 600. So that's a huge range. And so the way that the state misconstrued this is they said, oh, well, the data suggests that the local cancer rate is not elevated because it was not statistically different from the state average. And that is completely not scientifically sound, right? So this is a very important point, that just because there's no significant difference, that doesn't mean that things are safe, things are fine, things are the same as the state average. It really just means that the data are not conclusive. And so going back to Gianna's earlier point about effect sizes in small populations, what happened after this permit decision was made was that new data came out and the local cancer rate had increased. And so now that rate had gone from a little over 500 to almost 600 cancer cases per 100,000 population. And so it was now so much higher than the state average that it was now statistically significant. Did the state reconsider its permitting decision? No, right? So this kind of illustrates the challenge when we rely so heavily on statistical significance, because again, in small populations, you need to have a pretty high increase in cancer in order for that to be significantly higher than a state average or a control group. And so that's one reason why we encourage clients of our clinic to focus on cancer risk as opposed to cancer rates. So when I say risk, I'm talking about a mathematical estimate that can be directly attributed to one source. And so this map illustrates cancer risk at a neighborhood or census tract level across Louisiana. And it's data from the Environmental Protection Agency. So we can definitively say, you know, hey, people living in these communities where you have this pollution exposure, you know, according to EPA's best available science, have higher risks of cancer than other populations. Whereas if you talk about cancer cases, there's many different factors that contribute to the rate of cancers in a neighborhood. And so in Louisiana, we're fortunate to have census tract level cancer rates. And so Gianna and I undertook a study where we basically looked at all the neighborhood level cancer rates across Louisiana and compared them to estimates of pollution exposure, or specifically cancer risk from pollution exposure. Because ultimately we wanted to do two things. We wanted to see whether the firsthand experiences of clients of our clinic were supported by the cancer data, and to see whether or not toxic air pollution could be identified as contributing to our high cancer rate in Louisiana overall. And so this is a pretty different study design from what's being done in Pennsylvania, but I think there are some commonalities that are important. So I'm not going to get into the methods, but happy to talk about that if anyone's interested. And ultimately, these are the results. So this scatter plot illustrates cancer rate, right? So the number of cancer cases on the vertical axis relative to cancer risk from pollution on the horizontal axis. And each dot is a census tract, which is about the size of a neighborhood, right? So essentially, this is cancer rate versus pollution among all the neighborhoods in Louisiana. And the larger the circle, the higher the poverty rate. And the more purple the circle, the higher the proportion of Black residents. And the solid gray line is the national average cancer rate, and the dashed line is the Louisiana average. And so what you can see as you go along the horizontal axis from left to right and pollution increases, there are very few neighborhoods that have below average cancer rates, right? So regardless of, you know, regardless of the situation in these highly polluted neighborhoods, you consistently see very high above average cancer rates. And then if you look at the other end of the axis, you know, where the pollution values are close to zero, you have a really big spread of cancer rates. And again, that's because there's so many different factors that affect a neighborhood's cancer rate. So, you know, health outcome data are always messy, right? When I show this graph to attorneys, they're surprised that there's not a straight line relationship, you know, between pollution and cancer. But anyone who's worked with health data knows that it's never that clean. It's always messy. There's a lot of things that you can't control for in your analysis. And that's why you always need a big population size, because the larger your population, the more you overcome all of those uncontrolled factors, the more they tend to even out in the wash, I should say. And so we broke it down by numbers. And if we just take the high poverty neighborhoods in Louisiana, we can see that those that are also polluted have a higher cancer rate than what you would expect for a high poverty neighborhood. And there could be a lot of reasons why poverty status affects a neighborhood's susceptibility to cancer from air pollution. Something to keep in mind, especially in more affluent areas, is that people tend to move around a lot. In my neighborhood, a lot of my neighbors have moved in the last 5 years, and they don't represent, you know, the long-term pollution exposure in our area. So, you know, you always hope that a study supports your firsthand experience, but even if it doesn't, there can be many reasons why a study does not detect a link, even if that link exists, right? So ultimately, our study did support the experiences of residents of Cancer Alley. It's been published for anyone who wants to read into it in more depth. And to kind of sum up, what's really important, anytime we think about a cancer pollution study, we want to make sure that people's exposure to pollution is being measured accurately. Even if it's not being directly measured, is there some reliable proxy that the study is using? How is the study classifying people as exposed versus unexposed? And then are they accounting for people who are heavily exposed or moderately exposed? Are they also accounting for latency, right? It takes years or decades after an environmental exposure for most types of cancer to develop. So are they accounting for that time lag? And then are they accounting for other things like income status and access to healthcare that might affect a neighborhood cancer rate? And again, a lack of evidence and a lack of research cannot be used against any community, right? That's not conclusive. And any time that you're talking about a relatively small community, it's going to be challenging to demonstrate a link between pollution and any health outcome. And so that's why, we encourage people to shift the burden of proof to the polluter. It shouldn't be on the community to demonstrate a problem. It should be on the polluter to demonstrate that their actions are safe, because ultimately pollutants are known to have health effects. Right? These chemicals have been studied in laboratories, in occupational settings, and it's not a question of whether the chemical causes a health problem. It's a question of, are people being exposed to the chemical? So with that, I want to thank you all for listening. And I think we have time for questions, and we'd be happy to answer any questions you might have.
Well, thank you all for those presentations. And thank you for all the work you've done on this. This is so interesting. I feel like there's so much I want to talk about here, but this is a conversation that I've been wanting to have for a long time now, because the work I do with PSR, it involves reviewing the studies done on oil and gas build out in this region. And I'm also part of a coalition that asked the Pennsylvania Department of Health to commission further studies around a spike in rare childhood cancers in Southwest PA. And we are still awaiting the results of those studies. But we also have a new ethane cracker plant that recently came online in the region and already has over a dozen air quality violations. So, while these are issues that you were involved in Louisiana and Illinois, I wanted to bring this conversation to Pennsylvania, or just to any other communities out there that are listening, because we can learn a lot from each other and build strength through sort of shared knowledge and experiences. So, I mentioned that PSR was part of this coalition that responded to concerns over childhood cancers in the region. And the Department of Health is conducting 2 studies. One is looking at environmental links to cancer, and the other is looking at severe asthma and birth outcomes. And you all mentioned a lot of ways that studies can be problematic and maybe not give us a clear or correct picture of health impacts. But we're still waiting for the results, and there's a good chance that whatever the results are, they still won't be enough for policymakers to make any changes. So, communities are often told, again, no matter what the results of the studies are, that there's just not enough research showing direct causation. But how could we use existing research or existing scientific knowledge to make health protective decisions without waiting for this future research or using research that is flawed or incomplete? Is there a way to use what we already know?
That's a great question. Oh, go ahead, Gianna.
Well, no, I mean, I'll keep it kind of short and you can jump in. But I think something that, Kim and I used to say a lot when we'd present on the study is that, we don't need a study in every neighborhood to determine whether or not cigarettes cause cancer. Likewise, you know, if we know that something's carcinogenic, we don't need a study specific to every neighborhood to determine if that's going to cause cancer in that specific neighborhood. You know, it's okay to rely on more general studies that have been done throughout the US dealing with specific types of pollutants that we already know are harmful, you know, and especially dealing with just like limits on how much these facilities are allowed to emit. You know, there's no safe level of a carcinogen that a person should be exposed to. And I think that's ultimately what we really need to look at as far as the data available, as opposed to wanting something specific to each facility and each neighborhood and each person. So yeah, I'll leave it at that.
Yeah, and I'll really echo Gianna's points, and that's that typically I encourage communities to start with like the pollutant of concern, and then let's see what is out there for that particular pollutant. I know in the case of the you know, concerns about fracking in Southwest PA, the challenge is that you're not talking about any one pollutant, right? Like you're talking about fracking fluid, which goes into the ground with a mixture of toxic pollutants, and then it comes out of the ground with all of that, plus potentially radioactive material, you know, from its time underground. And so that is a huge challenge. And I saw, you know, Chris in the chat was asking, you know, what are your thoughts about the Pittsburgh study methodology in comparison to ours? I haven't dug into that study in a lot of detail, but just from looking at that website from the University of Pittsburgh, which I think my understanding is maybe there's two different studies. There's like the Department of Health study, and then University of Pittsburgh is doing a study, I think. Are they the same?
There's two studies from Pittsburgh commissioned by the Department of Health. It's confusing, but yeah, they're two studies, but they're both in Pitt, part of.
Okay. And it sounds like, just from what I read, it sounds like their approach is like a case control approach, right? Like they're trying to get people whose, you know, children have experienced or been diagnosed with this rare cancer, and then they're trying to find appropriate controls for that. So and then presumably they look to see whether, you know, whether the cancer group has a higher exposure compared to the control group. So my question would be like, how are they measuring exposure, right? Residing in a county where fracking occurs is a pretty imprecise measure of exposure. And we've seen in Louisiana, you know, our state decision makers trying to lump people together in based on, we have parishes here, but they're equivalent to counties based on your county of residence. And again, that's not very precise. And that's with respect to air quality, right? Like we all pretty much breathe, you know, the air that's outside. When you're concerned about exposure through groundwater, that's even more challenging, right? Because some people buy their water, some people drink tap water. So I think, you know, if it were me and I were going to ask some more questions of the state or of the university, I would really want to dig into, okay, how did you measure people's exposure, and how do you know that that's reliable? So yeah, that would be my first question.
I don't know if it was Kim or Gianna, you said something about how it was hard to find, like, you know, what do you use as a control when there's so much cancer already throughout your state? And I think about that in this region as well, where fracking and just other industries like are very widespread. So what can you use as a control? What is far enough away from an industry to be considered a control? And I don't know if there's a real answer to that, but I do think that's difficult to measure pollution when you're getting it from cumulative sources. And there's, you know, there are days they're operating, there are days that they're off, there's wind direction, there's just a lot of different things to take into account. Well, when you're looking at studies, and this is maybe just a very general question, are there like sort of red flags or green flags that would stick out to you all when looking at an environmental health study? Is there something that you would specifically look for to give it credentials or to be concerned about?
So I have this example of public health reports that were based on our cancer registry data that our state health departments ran. We had one from Colorado that focused on a city there with a sterilizer that took the approach that we've heard about, where there's not enough information to support harm. These numbers are not statistically significant, and they played into that narrative in their summary and in their discussion that there was nothing to worry about. And then we had our health department in Illinois take a very different approach to the study. They were used to doing studies by zip codes. And for our particular case, they saw that zip codes cross lines right around in this area. So they did a unique study that focused on census tracts, and they verified data block by block, address by address. It took them forever. But at the end, they had a very high quality analysis that they ran not just one way to see, the typical buckets they use, but they also split up time into smaller buckets to see trends of how these cancers were increasing in rate over time in our neighborhoods, from, including the time lag for them to develop from when pollution started till today. I mean, it was robust. And their conclusion at the end was, in broad strokes, we believe something is wrong, that these rates are elevated compared to what they should be, but that more studies need to be done in other parts of the state and around the country to confirm and to support and draw broader conclusions. So they took that step to say, it's not safe. We don't know exactly how bad it is, but we know there's a problem here and we need more. And I thought that was a very healthy approach, because it cut down that narrative that everything is safe.
Mm-hmm. Mm-hmm. Assuming guilty before innocence, or the opposite of that, exactly. There's a question here, I think, Ursa, for you in the chat about they'd love to hear more about what data their community collected and what crucial lessons they learned in order to ensure their data collection would be effective and influential.
We had a hard time with that. So the fun thing about ethylene oxide is, although it's been known for a long time, there's very little ambient air data that exists. And the modeling that EPA used was underestimating the pollution levels in our neighborhoods, and was underestimating global baseline generally. So I feel like we were at the beginning of a study. If you follow the story of lead and how its addition to all kinds of consumer products was removed, I feel like we're in the beginning of that lead study, where we're starting to gather data. But it was important to hire contractors that were not tied as closely to industry partners. There are a lot of contractors and a lot of groups that produce reports for industry that are paid for by industry, where the conclusion is ready before the analysis is done. Mm. So I think we got lucky in that there wasn't much data to begin with. And so we were looking at it with fresh eyes. They hadn't had a chance to do their spin on it yet. After our report, we saw the narrative shift from these contractors in their analysis of local data. So in Georgia, they used the same contractor to perform the analysis and the measurements, and the tone was different. It was like, getting that Illinois report here and getting the Colorado report for Georgia. But the ensuring data controls. We're not comparing to baseline. We're comparing to the risk values that there should be in the air. We're not comparing, the closest, locations to the facility and the farthest ones. We're comparing, we're going a little bit broader and not going just around our sterilizer or around our facility, but we're going far, like hundreds of miles out. California did a study on this pollutant where they went up and down their coast to try to get as clean of air samples as they could to find a negative sample. In Colorado, one of the ones that really stuck out to me is that they took a sample from a mile away and considered that their background level, their baseline level, as opposed to, the next block by the polluter. And we saw in ours that there were still significant levels. Our risk assessment from EPA, our final one, showed more than 100 in a million risk at 6 miles out. I mean, these distances are bigger than the assumptions the agencies are making.
Thank you for that. I don't think we have a whole lot of time left, unfortunately, because we had so much good information. But I do have a question. It's sort of for any of the panelists. Maybe a big question, but it's sort of saying that, here in this region, we've had some similar experiences in the sense that there were people who were experiencing health impacts. They were putting together that a lot of people that they knew were also getting this rare cancer. And yet they've been told by the government that it's not statistically significant, that it's not considered, a cluster, sort of that, like, there's no need for action because it's fine. Like, there's just this acceptance that people getting sick and getting cancer is just something that happens, and, they're not going to look into the cause or hold industry accountable. And so do any of you have advice to give these people, maybe around trusting their lived experience, taking action, or maybe working together with researchers to make a difference? So it's a big question, but whoever wants to start.
I think one easy question, when you are kind of faced with that narrative, assuming that you're talking to somebody who kind of understands the statistics, you can say, okay, well, how many cancer cases would it take for you to consider this a cluster, right? Because like in the case of, the presentation that we showed with St. James Parish, now the local cancer rate is 50% higher than the national average. And they're finally like, oh, okay, that's just past the threshold of what we can call, significant. So asking for that number specifically, right? Asking them if they've done a power analysis. So whatever the study is based on their sample size, how a power analysis tells you how big of an effect you would need in that sample size for something to be significant. And that goes back to the question of, how many cancer cases would it take? But yeah, I'll pass it to Gianna and Ursula. I know we also have a ton of questions in the chat. Laura, I'm happy to stick around as long as y'all want. But yeah, Gianna, Ursula.
I think kind of echoing what Kim already said, the work that we do at the clinic, like I said, is very client driven. So for anyone who, is experiencing these firsthand issues, and, we often hear from clients of the clinic that they've been telling people, and they often are like, well, where's the data? Where's the research that's supporting this? And unfortunately, the work that we're doing, like I said, is only valuable because it echoes what the community members have already been saying. We're just the ones that are trying to provide the actual data and research so that the community members can reference it, because unfortunately their firsthand experiences aren't being taken seriously often enough. So like Kim said, definitely ask what is considered, a number that is an issue. Any research that's been done outside of their specific state, I think is also good to have on hand. Like I said, just because it's a different area doesn't mean that the pollutant is going to behave any differently when it's put in a person's body. And just utilizing any resources that they have available, whether it's organizations that are offering research, or people who are just offering to kind of amplify the voices of communities via social media, campaigning, things like that. I think just bringing attention to it ultimately is kind of a valuable thing that we've seen work in a lot of communities that have gotten some changes in place.
And I would maybe add a couple of things to those. If you hear something that doesn't sound right, chip away at it. You won't always have perfect information to combat it, but take the statements that they're being made and see if you can reason or grab some data, even if it's not directly connected, that shows it might not be right. And just chipping away at those false narratives helps start that movement. The other one I forgot at this point.
Well, if you want to think about it for a second, I guess, we're technically at time. So if anybody needs to go, that's fine. But if you want to say and answer some of the questions in the chat, I think that would be great. But I do want to thank, everyone who did tune in, and to thank you all very much for your presentations. But I would love to keep chatting for a minute if you had. Great. I did notice that, Kim, that you answered one of the questions here in the chat.
Yeah, which I'm realizing I answered it, but only to the panelists. I don't think, so Chris, you have lots of great questions. I'm a little behind on them. But you were asked, and I actually think I misread one of your questions, so my answer was probably not accurate. But so Chris was asking do we know of a study about the effects of industry that has influenced policy? And the thing about pollution studies is they tend to focus on the pollutant from all sources, right? So like, as opposed to specifically oil and gas or fracking, but there's a lot of nationwide studies that have influenced policy. So I'll give you a concrete example. Right now, the Environmental Protection Agency is considering whether to make a more protective limit for PM 2.5 pollution. So PM 2.5 is fine particles in the air. It comes from things like Canadian wildfires, but also oil and gas activity. It's a very common type of pollutant. And over the last several decades, there's been a ton of nationwide studies looking at PM 2.5 levels relative to lung cancer, asthma, other respiratory diseases, COVID mortality. So that's typically how pollution research is generally approached, right? Because if I'm looking specifically at PM 2.5 from oil and gas, my study might be confounded by people who are breathing PM 2.5 from Canadian wildfires, right? So generally, you want to do the best job you can at measuring or estimating that pollution exposure.
Great, thank you. Trying to see what other questions we haven't gotten to in the chat.
I see there's one, I don't know if I'm understanding the question correctly, but I'm reading, has there been a cancer study regarding pollution from industry that has impacted policy?
Like, is that like a win story, maybe like something that they've proven a link? Because we've touched on this a little bit, but it's difficult to actually prove causation when it comes to these environmental or industry, exposures. I think that's really hard to do. So is there a case study of something like that?
And I kind of want to point out a fail study, if I could. So TCEQ worked closely with the Ethylene Oxide Sterilizers Association to help draft their competing risk value for the EPA's version, that national version of their risk value for ethylene oxide exposure. And so the studies that they used to support their competing value were these paid for their conclusions studies that are done by scientists outside of academia. And so there's a danger in figuring out who paid for the study. And so whenever you're seeing a supporting document or regulation, you should look at who paid for the study first thing before even looking at the conclusion, because they'll say something like, we know that the human body creates this, and you look into the details of the study, and there was no way to separate what was made endogenously and what was just inhaled from the environment when they did the study. And you're like, well, I can't absolutely say that. This is where that that science mindset that we have to look at the details and the conclusions needs to kick in and call it out.
That's a great point. And I'll also add that most scientific studies, when they're published, have a section on conflicts of interest. And usually there will be a statement in there that says, you know, the authors declare no conflicts of interests or no competing interests. Sometimes they do declare something, but to Ursula's point, of those, you know, industry-funded ethylene oxide studies, one of them, I can't remember, it either doesn't have that section or it says no competing interests, right? But then when you look at the affiliations of the authors, like they're working for chemical companies that release ethylene oxide, and they're studying the health effects of ethylene oxide. So, you know, it's a great piece of advice, you know, first thing, okay, who did this study and do they have a financial stake in the outcome?
As we, you know, await the results of the University of Pittsburgh study, you know, there is a chance that it won't show any link or any evidence. And do you have any advice for the community on how to respond to that if the studies are inconclusive, especially, you know, keeping in mind that people are continuing to have health impacts and get sick, and yet now they're going to, you know, perhaps would be told that the study results are inconclusive to take action.
Ursula, you want to go first?
Yeah. I'd say take what you have in the report. Take it, pick it apart. See, you know, how big were the buckets? To Kim's point, what was the power? What would it take? Do the statements that are made in that executive summary, are those supported by not only the data, but your outside view of, you know, the quality of what was selected in that data, the size of the buckets, where the control was, and poke holes where you find them to say, you know, yeah, this was inconclusive, but there were so many flaws with this study. Can we dig a little bit deeper? Can we look at another place that experienced the same thing and say, okay, you know, they've had their polluter there a little bit. Maybe it takes a little bit longer for these effects to become significant, or for us to see those trend lines build. Let's not wait for the harm to materialize. Let's just take the risks in that exposure and predict where we're going to be if we do this study in 10 years.
One of the impacted residents, she said something that was powerful once, that she said, how many of my friends have to die before somebody cares about this? And it's, you know, it's kind of a sobering thing to think about. Dr. Terrell, do you want to add anything?
Yeah, so I would add to that you could kind of use it as, like, assuming the study comes out and it's inconclusive. First of all, I would frame it that way, right? It's don't let anybody tell you that the study showed that there's no link or no problem or no evidence. If there's not a statistically significant association, then the study is inconclusive. That's what it is. Keep in mind that that threshold of statistical significance is 95%. So, and that's a convention used by researchers, right? Like it's not a hard law, but that's what it will be, because that's what it always is. So the study could come out and the researchers could say, okay, we are 90% certain that there are abnormally high rates of this cancer in places with fracking activity. And they would say it's not significantly higher, right? Because it didn't meet that 95% certainty threshold. It could be 94% certain, and they would still say, you know, that there's no statistical difference. So that's, you know, that's something that's really important to be aware of. And if that's the situation and it were my community, I would say, okay, well, the study was inconclusive, probably because it didn't do a great job of measuring people's exposure. And we need better water testing and better air testing so that we can measure people's exposure, so that we have a better ability to link exposure to health outcomes.
Yeah, that's great. There was one study that was done, I think, by the Department of Health a while back, looking at air pollution from fracking sites, and they did one 24 average, I think, every 7 days. of looking at air quality, and they said they didn't find anything. I think they did it on Sunday, a 24-hour average, and that was like the only data set that they used. So, and it's one that the industry likes to show all the time to show that they don't put out any pollution. And it takes digging into some of these studies to see some of the flaws of how inconclusive and incomplete they are. Gianna, did you want to add anything?
Kind of just like a mindset that I guess Kim and I often use, like when we're kind of doing the research, is that we kind of are anticipating a lot of backlash and issues from industry. So often when we're kind of doing the stages of research, after we think, this is kind of what we want to say, then we're like, okay, if I were industry, like how would I try and attack this? How would I try and like pick it apart? So that we're also like now adding things to the research that kind of makes it that much more concrete. And I think, if you're dealing with a situation where the study may not give you the results that you were expecting or hoping for, I think that's, like Kim said, and Ursula said, like, find the ways that the study could have been done better. Because ultimately, I think a lot of the time that is the biggest issue. It's not that there wasn't an issue, it's that the study didn't do the best job of including the factors that would capture that issue. So yeah, just try and really pay attention to the ways that things could have been done a little bit better, and even take the information that was given and try and apply that where you can. 94% certainty is pretty good compared to 95 in my eyes, and I know that statistical difference is always going to be referenced, but ultimately that's still good data at the end of the day.
And trend lines, they may not reach, even, 80 or 90%, but if you can see that trend line climbing over time, it's just, you're just waiting for it to get there to act. That's ridiculous.
Mm-hmm. Yeah. Go ahead, Kim. Sorry.
Well, and to Ursula's point, look at what the cancer rate is, right? Like relative to whatever your comparison is. It may be a situation where, this cancer rate is double the national average and it's not statistically significant, right? So don't stop at the part of the text that may say, no statistical difference. Figure out what that numerical difference is, and then hammer home the message that like, wow, our cancer rate is, twice the national average for this really rare childhood cancer, and they're telling us that's not significant, right? Mm-hmm. Hopefully that's not the case. And just quickly, Chris, with respect to your question about like accepted practices in how people talk about statistical data, absolutely, there's accepted practices. And the one key thing is always use that phrase statistically significant, right? Like if the Department of Health is coming to you and saying like there's no significant difference or there's no difference, always bring it back to, oh no, that's statistically, you're saying it's not statistically different, and that's not the same as like, is it different? Mm-hmm. But yeah, and also look out, there should be a section on the limitations of the study. Any good study should talk about its own limitations. And that's one like red flag we see with industry funded studies, is they never have any limitations, right? Like they're always perfect. So whatever the report, whatever the study finds, whether it supports you or doesn't support your experiences, there should be a section in there on, okay, these are the limitations. We didn't actually measure people's exposure to fracking fluid, right? Like we used this to estimate that. We have a small population size. So I wouldn't trust anybody who is unwilling to talk about how their study could have been done better.
Well, thank you. I think this has given me at least a lot of good information. I definitely was really happy to have these conversations with you and hear about the work you did. I mean, this is really important stuff that I hope is going to empower community members around here with our upcoming issues. And I want to thank you all for taking the time. And I think we'll wrap it up.
Yeah, I would just say thank you again for this. I feel that the amount of information that has come out of this is going to get a lot of communities thinking about how they can advocate for themselves better. And I think some of what you shared, Ursula, made it very apparent that the community has to take action, right? Like, we can't do it for you, even though we're there to support you. And the more the community is willing to take part in that fight, the better the outcome's going to be. And then to you, Kim and Gianna, I'm calling you by your last name. I don't think that most people know that there are resources like yours that can support them as they're thinking about how to go about the work that they're doing within their communities, especially small grassroots organizations. So I appreciate you all for sharing so much. And I have a feeling that you will hear from many people.
Yeah,
Thank
and I
you.
saw in the chat, we're more than happy to, if anyone wants to reach out for questions or just like where to find certain resources. That's part of my job at the clinic, is just to compile a giant list of resources for people, not only in Louisiana, but just like across the US that are looking for different data sources and just places to find information. So definitely reach out with any questions you have.
Yeah, absolutely. And if we don't have the answers, we have a list of people, individual people at these different resources that have served as our contacts that we're willing to share.